Hey everybody, my name's Caroline. Welcome to my channel. I'm an operating room nurse and I kind of just wanted to come on here and make a video explaining exactly what I do, just to help anybody who is thinking about going into the OR. I know there's really not too much information on YouTube for that, so I hope this helps. Basically, I have been a nurse for a little over a year. I graduated last year, May of 2018, and what's today? Today is October 26, 2019. So I've been a nurse well over a year and I love it. I went straight into the operating room. I didn't do any bedside as a nurse. I, however, was a nursing assistant for a little over 2 years in nursing school just to kind of throw me in, get me some experience. So I did that for 2 years and I definitely think that helped me realize that I didn't want to do bedside nursing. Not that it was... Honestly, I didn't even mind cleaning up people. It's really just, I didn't feel like that's where I wanted to be and I wasn't going to do something that wasn't going to make me happy. So I decided to go into the OR, kind of get experience beforehand. So we have a couple family friends that are physicians and I was able to get in with them. If you have friends, family, friends of friends, stuff like that, definitely reach out to them and see if you can get some hours in there and see if that's what you want, because that's what I did. And I think if I wouldn't have done that, I probably wouldn't have known how much I loved the OR. Ooh. Come here, bub. This is my little kitty. Hi. So yeah, I have a little bit of background with nursing assisting, and I definitely think it's a good idea if you're thinking about going to nursing school or in nursing school right now and just kind of want a little bit of that hospital experience. But let's get into my role as a circulator. So, currently I work in an outpatient surgery center. I don't work inpatient, so it is a little bit different with like the hours and call, weekend, stuff like that. So my current hours are, I work 4 days a week, 10-hour shifts. The day I have off alternates depending on the caseload and how many people we have on that day. So it's not the same every week, but I do know beforehand when the schedule comes out. I start work, I clock in at 6:40. We can clock in between 6:40 and 6:50, and we have huddle at 6:50. So basically it's all the nurses, the scrub techs, our charge nurses, and our managers get together and kind of go over the day, what we have, if any of the reps are coming in or bringing any implants or anything like that. And then also SPD, which is sterile processing, and they deal with the instrumentation, also people who order all the equipment, stuff like that. So we definitely have an in-depth meeting a couple minutes beforehand and before we start our cases. Sorry, that's my cat again. What are you doing, Wally? All right, so after that, that's around 6:50 and 7 a.m. Once 7 a.m. rolls around, we go to our rooms. So we have 6 operating rooms. We have 1 nurse and 1 tech per room, and we get the room started. So we'll wipe everything down, all the tables, turn on any cameras and printers that we have in the room. We turn on the Bovie machine, which is used, it's a cautery machine, which you use to cauterize tissue. You also get all the other equipment ready, so depending on what procedure it is, for example, if it's a gynecology procedure, you bring in something that's called the MyoSure. It's just specific to that procedure. So you bring in anything necessary that you'll be needing that day. And a lot of times we have more than one specialty in a room. So sometimes we'll have GYN, then we'll have general and plastics, pediatrics, stuff like that. So it's never the same every day, which is fun. So after I'm in the room and my tech and I are wiping everything down, turning everything on for the day, I look up my patient. So their H&P needs to be within 30 days. And also at this hospital, because it's outpatient, they need to be seen by the physician before we bring them back into the room. We check that. I also check allergies, check if they've had any surgeries and implants anywhere, such as metal, because we'll put their Bovie pad on the opposite leg or put it higher or lower wherever they have metal, so the cautery machine doesn't interfere with that metal. And then I kind of start getting started on my charting, not pre-charting like any patient assessment, but charting all the equipment that we use. They each have numbers on them, so obviously if something malfunctions, we can go into the chart and see exactly what number it was, and we can get that one fixed if needed. So I put that in there. I also add in everyone that's going to be in the room, sometimes residents, reps, other people helping out with counts and stuff like that, so I get them in the room. Definitely help out your tech if you have time in the morning. Cases usually start by 7:30, and so we get there we get in the room at 7 a.m. so we have around 20-25 minutes to go or to get the room ready, and then we'll go interview the patient. So obviously I'm gonna help my tech get set up, open up everything, go get something that he or she needs, and open up some medications, do some counts with them just to kind of get it out of the way. Obviously that's not always the case. If it's a bigger case, we'll have more instrumentation, and we'll just wait until the patient's in the room to do that and after they go to sleep. Or if we have anybody that is extra for the day, they can also help out with that. So basically between 7 and 7:30 we're getting the room set up and going to get the patient. At this time, at around 7:20, we'll go interview the patient, and I usually grab them a warm blanket. It gets pretty chilly once you get back to the operating room because we keep it that way for infection control. We'll look at their chart, make sure that they have an assessment in the computer and that the physician has seen them. We also need to make sure that anesthesia has seen them. They ask their own series of questions. All right, so after that, I'll go in the room as long as they're ready in pre-op, have their IV, and the pre-op nurse has educated them on certain things and whatnot. I'll ask them what their name and date of birth is, their surgeon is, and if they've been in the room already this morning. I'll ask if anesthesia has seen them. I'll ask about any implants they have in their body, when's the last time they had anything to eat or drink. Jewelry, make sure all that's off. Obviously, if you can't get a ring off, if it's been on, for 40 years and you have never taken it off, we usually put tape on it. Same thing goes for any earrings that people have. If you can't get them off, we'll just cover them with tape, but we do try to take everything off. Just it makes things easier. And yeah, so we ask if they have any contact lenses in, we'll take those out. They'll keep their glasses with their family members. We'll ask if there's anything loose in their mouth, loose teeth. And we'll also ask who's there with them today. If the procedure is going to be longer than 2 hours, we usually give their family members a call, so we'll let them know that. And I always double check with every family member whose phone number is written down on the sheet that we have in the chart. That's just if anything goes wrong. It could be the quickest case, but you really never know what's going to happen. So I just always double check that. And then I let them know that we'll be rolling back and we'll take great care of them, and then they can wait in the waiting area. They can also go downstairs, get some breakfast if it's morning time, or if it's going to be a really long procedure, they can kind of run some errands or whatever, as long as their phone's on them, so we can update them on the procedure. So after that, is when we're going to be bringing the patient back to the operating room. The second we get in the room, we hit patient in room on the computer. We have our anesthesia kind of get started on their thing, putting stickers on them, putting their blood pressure on, giving them anti-anxiety medication. But if it's a CRNA or a PA, they have to call and ask, not call and ask, they call and wait for, oh, sorry, butthole. We don't want to see that. If it's a PA or a CRNA, they have to call and basically give the medication under the anesthesiologist as he or she is watching. So after that, we'll have one of our other scrub techs or another nurse in the room double check that the patient has the correct wristband on with their name and date of birth, their allergies, and that they know what they're having done, which I didn't say that is what I do in my interview. I definitely ask in their own words, what are they having done? Because we don't want to mix up if they're supposed to be having, something to do with their uterus. We don't want them to say, oh, I'm having general surgery. No, that's not fun. The tech or the other nurse will ask those questions, and then we'll get the patient over onto the OR table. We do have a safety strap and some arm boards to kind of keep them secure and comfortable. We'll give them some warm blankets, and then we'll also put SCDs, which basically help. Oh, what do you have? So you don't get a blood clot while you're laying there for X amount of hours. Very important role of the nurse here is you stay by your patient until they're asleep. You don't run around. I usually stay by the patient. If there's anyone extra in the room, they can help count instruments, give medications, and, you know, get everything else plugged in. But I stay next to the patient, calmly talk to them, ask them, you know, some questions about their life just to keep them comfortable. And then we'll let them know to pick out a good dream when they're getting their medication to go to sleep. And you definitely want to stay next to them just in case anything goes wrong. You know, you're looking at the monitors, watching their blood pressure, heart rate, oxygen levels, all that. And I also stay there during the intubation. So if anesthesia needs any assistance with, you know, pressure on their throat or taking out the stylet of the ET tube, I'm right there, and I'm a nurse and that's what I'm supposed to do. You know, you're advocating for the patient, making sure they're as safe as possible. And yeah, so I make sure I am there until they're intubated. So after that, we'll get them positioned and then we will do the prep. So after the prep, I'll count with, if I haven't already counted and given drugs to the table to my tech, I'll do that. So for laparoscopic cases, we just kind of found out actually that we do not have to count the instruments. If I worked internally, not outpatient, we would have to count. There's always that chance of going open, but because we're outpatient surgery, you should be healthy enough and meet the criteria where you can be in and out with a laparoscopic case. It'd be fine. If there is a possibility to go open, the surgeon will let us know and we will count the instruments. And if they are too sick, then they'll go to the main ORs and have the procedure there, and most likely be admitted because an open case needs more monitoring afterward. All right, so after that, where are we at? We'll count, give medications. With medications, you always want to read the label of what you're giving to the tech and the percentage, you know, the strength of the medication, what the medication is, if it's local, you know, medication you're giving to help with pain control, you want to let them know if it's with epinephrine or not, and then the expiration date. This is very important. You don't want to give someone an expired medication because then you're going to have to fill out what we call a SAFER, and that can cause patient harm. So always double and triple check your medications. If you ever have any questions, obviously go to somebody, but we never use expired medication, so just rule of thumb, never deliver an expired medication. There was a time when I went into the Pyxis, which is basically our big cabinet of drugs, and I pulled, I think it was lidocaine or something like that, and it was expired, and I was reading it out loud to my tech, and it was like June 2019, and I was like, oh shit. So I kind of caught it right then and there, which I should have double checked it as I was pulling it from the medication machine, but obviously that was my fault. But that's why you always double and triple check before you're about to deliver it to the sterile field. So after all that, you're giving your medications, you've already counted, the surgeon's in the room or a resident, they're gonna drape the patient. So as they're draping, depending on what case it is, you have different kinds of equipment like light cables, insufflation tubing for laparoscopic case, the Bovie pad, and other tubing depending on what procedure it is. So you're going to want to get all that set up, primed if need be, make sure all your numbers are correct, they're to whatever they should be or the surgeon preference, and usually that's in like their preference cards that we have. So there's that, and then you guys are going to want to do a timeout. So the timeout that we do is with everybody in the room. So there has to be a nurse, there has to be a tech, has to be the surgeon, and has to be anesthesia. Now, it does not have to be an anesthesiologist, attending anesthesiologist. It can be a CRNA or a PA. So that's when we go over for the third time who the patient is, date of birth, their allergies, what they're having done, if it's a certain side, right or left. We go over their code status, which they all should be full code because this is outpatient and we don't want any DNRs. That doesn't make sense. So we'll do that, and then we'll also go over their fire risk. So fire risk depends on the prep you use, if it's above or below the xiphoid process. So any kind of procedure dealing with the eyes, the ears, the neck, the nose, and usually the breasts is above the xiphoid. So you got that. You got, if you have an alcoholic prep, and above xiphoid, that's automatically a 2. And then if you're using Bovie, which is the cautery machine to cut tissue, that's a 3. So you just want to take precautions and just know that you're aware of what can go wrong. So you're just always being ready. So then after that, then the surgeon will make the incision, and I'll hit that in my computer, and this is when I can start my charting. So we literally have to chart everything. We gotta chart when anybody comes in the room, whenever anybody leaves the room, what time incision was, what time we put medications on the table, what time medications were given, how much of a medication, where you put the Bovie pad, how a patient was positioned. My light just went off. That was creepy. How a patient was positioned. So, with their arms out, with their arms tucked, if there's foam protecting their hands and their elbows, if there's foam on their feet, if there's a pillow between their legs, everything. So if you didn't chart it, you didn't do it. And really you're covering your butt and you're just showing that you're caring for the patient, which is what we're supposed to do. A couple other things that we chart is, so after you hit that the patient was in the room or what time the procedure started, you also have to basically double chart it. So you do your pre-procedure timeout in the computer again, who was in the room, who did it with you, and then the pre-incision, which was everybody in the room that was involved, and the fire risk. That's where you kind of chart the fire risk, what prep you use, stuff like that. And then you also chart their skin assessment. That's actually what I'm looking at when they go to sleep and when we're positioning them. I kind of make sure that there's nothing that needs to be addressed beforehand, because if there is, I'll put that in their pre-op skin to show that it was not our fault, it was there before. And then we'll chart where we put the Bovie pad, we'll chart all the different settings, we will put numbers in for other equipment that we used, like I said before. We'll put the counts in, who did the counts. Oh my gosh, there's so much and I can't even think. I'm like going down the list in my head. There's that, there's allergies, making sure you address the allergies. Yes, buddy. Oh, another big one is supplies. So just make sure you're charting the very expensive items. There's also a tab for procedures. Now, a lot of times on the consent, there will be more than one thing or a possible XYZ, what they're gonna do. And that'll also be in the computer. But in the computer, it'll say possible this, possible this, possible this. So you always wanna make sure that if the surgeon did that, erase the possible because they did the procedure, or completely take it off the record, because that will lead to a lot of confusion if the consent said one thing and then the surgeon said one thing in their dictation note, but I chart something else. So you just want to make sure everything is the same everywhere and there's going to be no confusion at the end of the day. As I'm charting, I'm keeping an ear out for anyone that needs anything. If the lights need to be turned off, if something needs to be turned on, like the insufflation machine for laparoscopic cases to open the belly, make sure they have visualization there. I'm doing that. I'm calling anybody that needs to be called, x-ray, any of the reps that are in there if they need help, or usually we have to be the ones that are touching the equipment and stuff. They're really not supposed to, but they can tell us how something is supposed to be used or what to do with it. So I'm definitely moving around a lot and then charting whenever I have some free time. I glance at the vital machine. Obviously anesthesia's watching too, but I like to keep an eye out. Just, it's my patient. I want to make sure they're safe and they're okay. So I'm running around making sure everyone is happy, putting on some music for people. We gotta have fun in the OR. So basically just charting until someone needs me. I freaking love charting, and I know that's like really like something stupid to be excited about, but that's like the one thing in the OR that like I love doing. Like I love when everything's going perfectly and like we're listening to good music and I'm just charting and we're having a good conversation. It's just a fun day. So obviously when you have super quick cases, when they're like 2 minutes, well, it feels like 2 minutes, charting is a BITCH, but yeah, I don't know why I like it. I'm just there basically if anyone needs anything, making sure the patient's safe, grabbing anything else that the surgeon asks for, or if our tech needs something. I have like a list of stuff on my computer. Oh, one thing that is awesome is, I don't know if this is everywhere. Sorry, my knee's in the way. I don't know if this is at every hospital. It was at the first one I started at back in Cleveland, Ohio. I worked at the Cleveland Clinic. They had surgeon books, and these were a godsend because when I first started, I literally didn't know anything because we don't learn surgery in nursing school. Obviously, you go, really everything's bedside. But anyway, these books literally say, for this procedure, I need this, like every single supply and equipment piece you can need. And then it was a step-by-step of what they do for the procedure and using what suture or what you need next. So it was definitely was a lifesaver when I first started because I was already nervous enough. That just kind of gave me like a peace of mind and kind of helped me learn what they needed next just to make them happy and kind of ease my way into this, new job. So at my outpatient center, we have what they're called preference cards. It's really the same thing, but when you bring everything in the room, they have their card and then who the patient is, who the surgeon is, what glove size. Sorry, my camera stopped recording. I think I was talking about preference cards. So it was basically literally everything you need to know, what kind of prep they use, what size gloves they are, what size gown they are, what they need for the procedure, all the supplies, what medications, how much medication, if they're going to inject before or after the case starts, well, before incision or after the case. There's usually what dressings they're going to use, and also stuff to have in the room. So basically stuff that's going to be on hold, so don't open it, but just keep it in the room in case they need it. I know I'm going kind of back and forth with things. Sorry, I'm not really going in order. My brain's scattered. We do 3 counts, at least 3 counts for every procedure. You do a count at the beginning before you make incision. You do a count as you're closing, or when they begin to close, that's when you do your closing count. You count all your sponges and your Raytex, which laps and Raytec are different. So if you go to the OR, you'll know that, but the 2 different kinds of sponges, all your sharps, like your knife handles, your needles for injection, and your needles for suturing and stuff like that. Anything that's small that could get lost in the body, basically, that's what we count. We'll count bases, which they're basically clips, instead of bovine. If there's a bleeder, you have a clip that you clip on the ends to stop the bleeding. So we'll count those. Vessel loops, depending on what procedure it is. For laparoscopic cases, there's something called a Fred, and it's 1 or 2 pieces, basically a bottle of fluid and a little pad. And if the camera for laparoscopic cases get foggy, you just squeeze a little bit on the pad and put the end of the camera on it, and hopefully it helps. And basically anything else, we always add to the board every time we hand something up. So that's also very important. You want to make sure, I usually keep whatever I have in my hand that I just opened, if I know I have to count it, so I remember to put it on the board. So that's your closing, or your first closing count. And then your final count would be before the dressings go on. So you're basically doing the same, counting everything that you counted the first and second time, making sure it's correct. It's time for the patient to wake up. So this is when it gets a little crazy. We have to unplug everything. We do all those counts. We put up dressings. We're calling the PACU, letting them know where they're going, or if they're going to come in the room and get the patient, because we're definitely a small hospital, so or outpatient center. So we really only have 6 operating rooms and 10 pre-op and post-op rooms, I think. So it's not a big hospital where you have to go, across the building to the ICU or something. So the pre-op and post-op nurses do come in sometimes to get the patient, just to help with turnovers and getting the room ready for the next patient. So we're calling them, we're calling out overhead, letting them know that we need help with turnover and moving help. And then we'll get the patient positioned where we can move them over to the stretcher from the OR table. I'll get them some warm blankets. Make sure that their bovie site where we put the pad there's no redness or skin tearing or anything like that. Make sure, depending on what dressing it is, making sure it's dry. If it's Dermabond, which is like a skin glue, we use that for small incisions like laparoscopic or something, making sure that's dry so we don't put their gown or a blanket over it and then have it get stuck and if it's not dry, it's not good. We want to wait till it's dry. And making sure all their other dressings aren't saturated in blood, making sure they're clean. And we'll do that. We'll get our specimens, make sure we have our specimens. Usually for most cases, we will have our specimens before the case is finished. However, for some cases, if it's a quick case or it's a GYN case, some specimens go, they're like in another piece of equipment because the suction tubing was attached to it. Before the surgeon leaves, if we have any questions about a specimen or what the procedure was, if there's any like miscommunication, or we just want to double check, make sure everything's correct for the procedure and what exactly they did, I'll ask them that. Make sure that's in the chart. We'll do a debriefing, which is basically after the procedure. If everything went well, if you have all your specimens, everything's correct, nothing bad happened in the room. And then it's basically just like a, hey everyone, we did this with this patient, everything went well, dressings are on, medication's good, she's good or he's good. Get the patient moved over. Anesthesia is obviously at the head of the bed. We have someone getting their feet, and then we have someone on either side of them. So we'll have a big roller board. We'll cover that with a sheet. One person will put that under one side of the patient, and then someone else will be on the other side, kind of flipping them over so the board can go under them. So at least 4 people total, depending on the size of the patient, moving them over to the stretcher. We'll put both the side rails up. Anesthesia will do their thing. If the patient's not extubated yet, they'll monitor them, and we're just getting ready for the next case. Wipe down the bed. We wipe down any equipment we used, and we wait for the pre-op nurse to come in, or if we're going out with the patient, we take them out. So usually, what we've been doing now to help with turnovers is the pre-op nurse will come in, we'll give them a report, name, date of birth, allergies, what they had done, what kind of dressings they have on, what medication they got, and who's there with them. Usually I'll tell them that, because sometimes you just don't know by looking at someone. You can say, oh, that's your husband. Well, no, that's their friend. So you can't really tell them as much information about the patient without breaking HIPAA. So you want to make sure that you know exactly who's in the room with them, or what family or friends are with them. There's a lot that goes on, and it's fun. I know it, not always, but honestly, just like looking back on the past couple months so far, where I'm at in the outpatient center, like it really is a great job to be at. I love the surgeons that I work with. Everyone, nurses, techs, charge nurses, managers, directors, like pre-op and post-op nurses, and the care partners and SPD and people that order materials. I mean, everyone is so close, and everyone knows who each other are because it's such a small center. Or you see each other in the hallway, and it's awesome. I mean, I really do love it. I love advocating for my patients. I love having one patient at a time, making sure that they're being taken care of to my best ability, and that everyone else is taking care of them, making sure no harm is going on. And I mean, it can be very, very difficult depending on what the case is. You're not always going to have as much fun as you are some days. It's just not going to happen. But I definitely have more good days than bad, and the bad days usually, there's really no bad days. Sometimes I'm just not in the best of moods, and then you're with someone who's not in a good mood and stuff like that. So I don't really have horrible days. I have been at my outpatient center since July 15th of this year. So July, August, September, October, a little over 3 months. And I've been off orientation for a little over a week. I've really been on my own for more than that, but officially off orientation for over a week, and it's been phenomenal. I feel like a different woman, and I know that's weird to say, but like you don't have someone to always or to second guess you or to kind of go to. You've really got to think for yourself, and that definitely makes me a better nurse. I sometimes in cases where I'm like, I kind of overthink it in the morning, like, oh my gosh, like what if I forget this or what if I forget that? It's okay. There's always going to be people there helping you, and sometimes you just got to tell people you got to wait a second. So at the end of the day, it's a great job. I freaking love it. And I guess I'll kind of tell you a little bit about like my hours and the pay, maybe. So I work 4 10-hour shifts. I originally worked 5/8, which I do like, but at the same time I work 30 minutes away, so in Atlanta traffic it kind of sucks. But I'm going to be working 4 10s, which is awesome. I'll have 1 day off, which thank God I get to sleep in. I love sleep, so I would rather work 4 days a week. So there's that. Pay is great. After I got orientation at the hospital where I'm at now, I got an increase of $5 an hour, which is amazing. I honestly have never really heard of making even more money when you're off orientation unless you go to night shift. But that was definitely a surprise before I started, and I was, you know, it helps you kind of work through all the hardships. Like, it's definitely an incentive to think about. I don't do any weekends, any nights, or call because we are not an inpatient facility. We are connected to the hospital, but we ourselves are our own entity. We don't do anything on weekends. We don't do anything on holidays, like Thanksgiving, Christmas. What day do we have? Oh, I have Halloween off this year, which is just my random day off. But yeah, stuff like that. So it's good. I'm happy we don't have to work nights, even though we're required to work 2 lates a week. So sometimes you're the last person there, but it's not always super late. It's maybe 5 o'clock. So it's not that bad. But yeah, I think I covered everything. I hope I didn't miss anything, because that would be kind of awkward. Any future nurses or anyone in nursing school thinking about going in the OR, please let me know in the comments how you thought of this video. If you have any other questions, please let me know, and I'll see you in the next video.